Welcome to the Education Pre-Hospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsor, Limmer Education, we can make science more accessible and understandable. Okay, welcome everyone to the December 2022 Pre-Hospital Care Research Forum Education Research Journal Club. We have a new format here, so we're getting our technical aspects kind of ready here. I'm Megan Corey. I will be, Dave Page will be joining us. A few others will be joining us right now. We've got Alex Tremblay. We have, now Kim McKenna's not on yet and Katie's not on yet, but they'll be coming in too. And we have Michael Caduce from UCLA. We've got Dr. Bill Toon from Arizona. Yay. And we want to thank Limmer Education for sponsoring all of our journal clubs. We have a really special episode today. We are calling this the best of educational research in 2022. So each of our panelists, and there'll be a few others joining us, are going to be sharing some research from this year that captured their interest. So thank you. Let's begin. We're going to remind you that you can use a chat feature. This is Zoom now. You can use the chat feature and we can, look at your chats and kind of pull it in, any comments that might be related. You can also use a Q&A function for asking a question of the panelists as they're presenting their research. And we're going to be watching the time here. Remember that you can quote, tag, share. If you hear something that you like, hashtag EMS research, and of course at PCRF at UCLA, as well as our sponsor, Limmer Education. Really quickly though, Dave Page isn't on yet, so I'm just going to announce this. There is a special, we've had just research galore journal clubs this month, and we had the clinical, now we're having the educational special. Next week, there's a special journal club on workforce diversity. That is on Tuesday, December 20th, 11 a.m. Pacific. Watch the new time. It's a different time. It's an hour later than usual, 2 p.m. Eastern, 1 Central. So that'll be a special one, a conversation about workforce diversity. There'll be the National Association of EMS Physician Diversity, Equity, Inclusion Committee presenting the science behind the importance of workforce diversity. So don't forget, that's a special journal club coming up. Now, remember, we also have a YouTube channel. So if you miss any of these, you can come in and check out our archives on our YouTube channel. And this is youtube.com and then /PCRF at UCLA, and you'll see all of us. You can subscribe too. So you can click on subscribe. You can see I'm subscribed because that's a screenshot of mine, and join us. Now, what a year we have had. This shows you what we've done in just this one. And remember, the YouTube channel is not just the Education Journal Club. It'll be the Clinical Journal Club with Dr. Remley Crow, Dr. Tony Fernandez, and any other special ones that we have. If you just kind of glance through the topics and just talking to our panel who've been here or listened, look at some of the topics and the guest researchers from education that we've had over the past year. Well, we started with that review of the NAEMSP Airway compendium. We bridged to this great study on the hybrid lab, and that study out of Lithuania. We did a special live session from AccreditCon from the conference, and that was in June. And then we welcomed a really special guest, the Dr. Louis Nadelman from, I can't remember exactly, he was from Colorado, but also from Arkansas, I believe. And he discussed his important research on faculty mindset, on equity and growth mindset. We've looked at studies on teaching methodologies, like the pediatric study recently published in the pre-hospital emergency care. And we looked at clinical judgment models with Kim McKenna in EMS. I mean, that's a lot. So what we're going to do today is we've kind of asked our panelists to think about how research has changed their thinking and teaching about teaching and learning, or altered their practice and education, and maybe pull an article that really resonates with them and share it And each of us is going to share some research. And just so you know, we will have the references for all of these. If you can't jot down quick enough, or you're just listening, we'll have the references in the notes section below the YouTube recording. So when we post the YouTube recording, we'll put the references for all the research that we're talking about today there, so you can get them all in one. So let's begin. And we're going to start with Mike's pick. Michael Caduce, you want to introduce yourself first? Because you're not a regular here. Introduce yourself and let us know what you've got here.
Thanks, Megan. I'm a regular listener, first-time caller. Thank you for having me. I'm thrilled to be joining you today and sharing some great things about research. So my name is Michael Caduce. I'm the EMT program director here at the UCLA Center for Prehospital Care. I'm thrilled to be able to help work with a team that educates over 1,000 EMTs every year. When picking the best research of the year, there's a list, and I probably have a stack that I could choose from. But one of the articles that I don't think got as much publicity. Like the Airway compendium comes out and everybody goes crazy, and that's great. We want people going crazy over research, but this is an article that I've sort of kept in my back pocket for a while because it is impacting our program specifically. So this is the Child Opportunity Index in pediatric emergency medical service utilization. So this was published this year in PEC, and it details this index. And I had not heard of this index before, but now actually have some ideas for how you can incorporate some more research. So let me tell you a little bit about the study. So this study took this Child Opportunity Index and compared it with EMS utilization. And so for those that don't know, the Child Opportunity Index provides a multidimensional population level composite measure of neighborhood level indicators that assess structural, economic, and environmental conditions. There's lots of different ways to measure a community. Access to healthcare, car owner occupancy can help tell us if socioeconomic status, things like that. But this is actually a 2018 study that uses a multidimensional approach to look at communities. This study, which is by far one of the most robust studies that we've seen in terms of how we look at a community, they took that and compared it with EMS utilization. And so the COI uses some quartiles, and they took those quartiles, compared it with utilization in NAEMSP. So again, big nationwide study, over 1 million impressions in this study they looked at. So I like that. And actually what they found was we are going to a disproportionately higher level of patients in the lowest COI, which would be those that are the lowest socioeconomic status, but other things as well, because again, the COI takes lots into account. I think we know in EMS that we treat kids and that we're probably not great at treating kids because we don't see them often enough. The thing I took out of this study is we're treating a lot sicker patients in this lowest COI status. What does the discussion tell us, or what can we extrapolate from that? Well, we can extrapolate from that maybe less access to healthcare, less access to medications is causing our patients to be sicker. I think oftentimes we like kids because for the most part, they're very healthy, they're very easy to manage, and it doesn't require a ton of effort on the pre-hospital setting. But what we're seeing in certain populations is that they are sicker. And this study actually looked at that and looked at administration of respiratory medications and found that more respiratory medication was administered in the lowest COI, again, for some of those other reasons that I mentioned. That tells me we need to make sure that our EMS providers are educated in caring for sick kids, because they're going to be, especially for those that don't have the access to healthcare, the access to medications, transportation to medical visits, things like that. How does that change our practice? We've also looked at some of the quality assurance information that's come out of Los Angeles County, and we've seen some undertreated pediatric patients for seizures as well. So we are rolling out come January a whole CI service. We're bringing our entire staff together. We have over 35 educators on our team. We're bringing everybody in for a 2-hour session where we're going to be doing some review of pediatric education, and we're updating all of our equipment for the skills labs for pediatrics. So in some of our labs, we have very high fidelity, realistic life cast mannequins. In other where we don't have those mannequins, or where we don't have the funds to just spend to put those mannequins in every lab, there's a couple companies out there that make life-size posters of kids and scenarios associated with them. So we have kids of all different age ranges, all different backgrounds, all different genders, races, ethnicities, so that our students get an opportunity to see a patient. I think if you asked our average 18 to 24-year-old EMT, how much does a 4-year-old weigh? How much does a 10-year-old weigh? Or we put a 10-year-old in front of them and said, how old do you think this this child is, they probably wouldn't answer as correctly as if we asked them, how, what's the average heart rate of an adult. So we're doing a whole renovation of our education for pediatrics. We're writing lesson plans and case studies for our labs so that we can prepare our educators to go on and teach our students the difference that comes with pediatric education and making sure that they can recognize sick kids when they see them. We're doing that again in the lab with some high fidelity simulation, with some lesson plans. We can't just put the mannequins in front of the students and hope they'll learn. We're going to write some lesson plans, but we're going to start that with our instructor education levels in January and roll that out to our students starting in 2023. So, and actually what this study was the sort of the leading factor in us recognizing this was what we wanted to do. Our full-time team said, this is what we want to do come January is our big push for 2023.
Mike, this was reviewed in, did Dr. Crow and Dr. Fernandez review this article with I believe with a researcher in one of the PCRF clinical journal clubs? Is that correct?
They very well could have. I try and listen to all of those. I may have missed this one. If they did, great. I think it's a great study because again, we don't have a good index to use, and this COI really is recent, updated, pre-COVID. Dave Page is saying yes, they did. So I don't steal their thunder. If you want to go back to the YouTube channel and watch their review of this, I think this is a great study from 2022. One of my favorites.
Great, and I do want to direct people. I'm pretty certain I listened to Dr. Crow interview one of the authors on this. Dave Page is here. Dave, did you want to unmute and say anything about this? I can see you on as a.
Yes, thank you. I'm having all sorts of technology issues and love the pick. So good job, Michael. This COI and just highlighting the inequities of care for children and was a fantastic webinar, and I'm going to find the link and put it in the chat.
Great. And I'm not sure if little boxes are appearing in front of the screen, but I see in the Q&A we have a comment about Michigan developing medic cards that assist with all the items you spoke about. Dr. John Hoyle can post the link to the cards from the Michigan website. So thank you very much for doing that. And so any questions from the panelists or comments about this for Mike about the research? Just a terrific pick.
I think it speaks again to the importance of the social determinants of health, right? Even if that's not the core function of the paper or the only thing that we take away from it, right? Is that over time, there's a lot to suggest that provider satisfaction, provider burnout has to do with a lack of that understanding of social determinants of health, which I'll talk just a little bit about here in a few articles. And so I thought this was an excellent pick, Michael. Well done.
Yeah,
Thanks,
Great segue, because that actually fits with my pick. So I'll just transition really quickly and give you my quick pick. And you're going to see a lot of this common theme. And we independently chose these articles. That's what's interesting. We didn't even really talk to each other about it. So I chose this article called "I Certainly Wasn't a Patient as Patient-Centered: Impacts and Potentials of Cross-Training Paramedics as Community Health Workers." And I chose this, it's a qualitative study that explores the cross-training of community paramedics as CHWs. There was an article many years ago by Matt Zavadsky. This is at the dawn of community paramedicine, and then later and years later by John Tadero in EMS 3.0 that talked about we should be using the community health worker core curriculum as the foundation for community paramedic. Kind of disappeared from what I could see at that discussion did. I'm actually happen to be from an area where our college, City College of San Francisco, has a very well established community health worker program. So and a lot of people may wonder what is a community health worker. That actually was something they address in this article. A community health worker is something, if you look up and it's a global thing. So if you look up on the World Health Organization site, they actually use the American Public Health Association's description as a frontline public health worker who's a trusted member of or has an unusually close understanding of the community served. They often are from the community they work within, share demographic similarities like culture, race, ethnicity, gender, and sexual orientation with their clients. And they also sometimes have a shared lived experience, meaning that they were themselves homeless or had substance use disorders or mental health disorders. Also, interestingly, on a health finance note, a lot of the CHW specific services are Medicaid reimbursable. So that was another reason this was raised as a topic in the past. So what this author did was they have an existing community health worker program in Indiana. So this is out of Indiana, and specifically a program in Indianapolis, where they had 49 community paramedics that were cross-trained as CHWs, and using participant observation and semi-structured follow-up interviews on 6 of those community health worker cross-trained community paramedics. This researcher used a public health framework to evaluate the impact on what that did for these cross-trained paramedics. It was done because of an identified problem, which was a negative impact on the caregiving, and caused by kind of a lack of understanding of the foundations of the social determinants of health. So they used a public health framework, which does, again, it's an undergird of the CHW. It's a socio-ecological model and the social determinants of health model. And these describe how a person's health is shaped by more than just behavior and biology, and the conditions that impact the ability or the opportunity really to achieve good health outcomes. And so they provided this training to the paramedics and then followed them. This was over about a 5-year period. What the results were, that they found that the community paramedics reported a much deeper understanding of the social determinants of health and well-being in general. And that the original goal of the community paramedic program, which was readmission reduction and seeing an X number of patients per day, was causing pressure on them, and they felt that negatively impacted their caregiving. And by having this CHW training, it adjusted their mindset. Those were the terms. And again, we've talked about mindset this year a lot, mostly from the perspective of faculty, but adjusted their mindset, made them better at listening, following up, patient advocacy, recognizing patient autonomy and empowerment, compassionate care. And this is an open access article. I would strongly recommend you read it for some of the quotes that come from the paramedics. One who said, "I should have had this training to begin with. This was the training that I needed." They did recognize some challenges. One was that they really felt that the community paramedics said, they can't believe that healthcare workers don't know what a CHW is a lot of times, and they felt that the hospital should have them on staff. A lot of them do. I know around here we have CHWs are sometimes called promotores de salud. We have promotores programs around here. Sometimes they're patient advocates in the hospital to help them, patients navigate things like insurance and other things and instructions. The other challenge they said was training costs, and that must be specific to their region. I was sort of surprised at that, but that's because I'm from a very low cost community college area. And since community health workers are usually from the community, and we have a program called Free City where they can get free community college education, I was surprised at the training costs. It was like $1,500 for them to train a single community paramedic to be a CHW. And here it would be pretty much free. But they also said that the challenges, they didn't always find success, which I thought was interesting. We're always looking at, it's VFib, I do CPR, I cardio, or I do defibrillate the patient, and I continue to run my ACLS algorithm. And that's just not, that's a medical model. That's not really how, health, the CHW job has a lot more depth and modeling around the social determinants of health, which are more complex. They concluded that community paramedics should be cross-trained as CHWs, and that their program caused a positive impact. But my opinion is they missed one thing about this, and I'd love to say it was my idea, but it was really Sam Scow, who is a graduate of mine who did go through a CHW program, who came to me and said, I think we should be recruiting EMS workers from the existing CHW workforce, especially if we want to tie this into some of the DEI issues that you're going to be talking about on Tuesday, Dave. so again, the CHWs and promotores de salud, these tend to be integrated in the community, very well established with their, with their clients. And so it's one of the ways to discuss how to address workforce diversity in EMS is maybe pulling from or encouraging people who are current CHWs to be EMTs. So that was the study. So
Love
Dave,
it.
Yeah. And I, like I said, I'd love to say it was my idea, but it was really Sam Scow's, who is a graduate and a PCRF researcher from this year.
Yes, he attended a workshop we did with ESO in Austin, and he has a paper that he presented at EMS World, and I think also got accepted for NAEMSP. So fantastic, and 100% a fan. I think that the concept of reaching into the community and having them participate is, they're already health advocates. They're already trying to negotiate and navigate the nightmare of access. And I think this is a perfect opportunity for that. I also, a little bit more about what the CHW curriculum looks like. It's a easier lift, I think, in some cases than even an EMT class, right?
Yeah, well, it's a different kind of lift. The other problem is that CHW training looks different in different places. In some places, I think there was like a 70-hour or something training program. And, here it's a certificate program that's 2 semesters. It really depends. The core concepts and standards are the same. There is a move toward, a little bit more standardization, but they want the flexibility too, because again, it's sort of a global thing and it really depends on community needs. So on what the local needs of the community are. So, but I thought too, interprofessional simulation would be that there's an opportunity as well. Instead of we do all this interprofessional simulation with other kind of traditional medical people like nurses and doctors and others. Why not with some of the more, the social workers and CHWs and, healthcare interpreters and that aspect of healthcare that we're talking about. So, and speaking of simulation, that brings up our next pick, Katie. Welcome.
Yeah. I mean, I was just about to say any opportunity for interprofessional simulation we should jump on, right? Like we need way more of that. I had a hard time picking my favorite research articles. I'm sure everyone's shared that so far. So I picked a couple around simulation. These are from Society for Simulation in Healthcare. And the first one was paramedic student performance during high fidelity sim after physically demanding occupational task. So I think one of the things that I'm always interested in is how we can make the lab and our simulation and our skills more realistic to the real world. And so here they had, in this study, they had them do a physically demanding task. So they like something that would make your heart rate go up, and then you have to climb stairs, you have to, do something, carry equipment, heavy equipment up to the 5th floor, walk up, of the apartment. And then they had them run a code where they had to do compressions. So one group was resting. So you could say that you're like the group that's chilled, sitting back in your recliner at your fire station versus the group that's posted maybe somewhere and has to run back to their ambulance. And it turned out that the group that had to do the physically demanding tasks actually performed better. They had better performance when they were doing the CPR simulation, which is kind of not what we would expect. I think not what I had expected. And so it was really interesting. And the interesting part too is they were looking at their conclusion was that the students potentially need more experience and less physical fitness. And I'm not quite sure how they got to that, but they definitely said that maybe we should be thinking more about less physical fitness in the paramedic and the workforce, but more experience with medicine and clinical reasoning, which also hard to argue with that. So interesting result there. And then the other one was with Association of Simulation Participation with diagnostic reasoning. And this was actually done in preclinical medical students, but I think that's a group that has a lot of overlap with like paramedic students getting ready to go out into internship. And what they did was they had volunteer extracurricular simulation sessions. So they said, hey, if you guys want to come do some mannequin simulation, we can do that, and hopefully it'll work on your diagnostic reasoning scores. So they had a bunch of different groups, and they actually controlled for self-selection and like bias of, well, the kids that are going to do extracurricular activities, maybe they're the ones that are all going to be better anyway. So some of them volunteered but weren't able to make it, and so they put those in a separate group to try to stratify. Is it just students who want more help are going to be doing better anyway, or if it's the actual intervention? And it turned out it was the actual intervention, that when the students who were able to perform in more simulation sessions were evaluated by physicians on their diagnostic reasoning, they had higher scores. So it looks that there's a dose response pattern. So the more simulations they do, the better they got at diagnostic reasoning. And so for me, with these two research kinds together, and Megan, if you would have given me 17 slides, I could have found 17. There was another one that was looking at the level of stress in the simulation. But it seems that the more that we make it realistic, like we make them carry their gear up flights of stairs, we make them do multiple simulations, they are getting better. So all of this like time, effort, energy we're spending in education, if we put it to the right spot. And I think Dave Page is on this call. He would say that, yeah, of course, if we do more active
of course, yay, cheers, cheers. I
like,
love this. I love this.
Yeah, but I know Kim's there too, right? We're all like, this is what we're doing, and all these like smart people are publishing in these journals saying what you're doing works. So this is the like, hey everyone, it's the end of the year, we're going through finals, you're probably all stressed. Turns out all that hard work you did is valid, it's working, it makes them better at diagnosing patients, and it makes them better at their job. So yay, congratulations everyone doing the right stuff.
I think this sort of goes along with the work from like FISDAP work from a while back that, you know, sort of speaks to, you know, the more ALS team leads that you have, the more ability that you have to answer those critical thinking questions. And I think, you know, when you're in the sim lab, you can really control for what they are seeing and sort of target things. And so I'm with you all the way on this one. I think this is amazing.
Yeah.
I love this. Like I love it so much that I just had to turn on the camera and go, ah! Because you just man, I just think, remember that study, Katie, where they were swabbing for enzymes and realizing, you know, that zone of proximal development that Megan Corey loves to talk about, that I fully support, and pushing envelopes, you know, sort of the wearing in of the synaptic connection in the brain so that the memory paths get cemented, and it combines all of the brain-based learning, all of the immersive learning with that concept of, you know, the more shortcuts you take, the more you make it unbelievable, the more you verbalize, the less education there is. So all of that immersion into, if you have to intubate on the floor, there's a physical response required from the learner, and making the decision on the floor, this is my time to actually ventilate, or this is my time to stick the laryngoscope in. This is my time to hook up the monitor, or this is my time to simply stroke somebody's hair and say, it's going to be all right, we're going to take really good care of you. These are indelible marks on students who are immersed in the education. And all we have to do really is make it real, just make it real. And I am thrilled that you picked those articles, because it's repeatedly showing us the more reality, the better. So look around you and get rid of anything that's just fakey and verbalization, and get the most out of the reality that you can.
Now, to channel Bill Toon here too, I would say, and Bill, you can jump in here. I would say too, we'd like to translate that too into, you know, when we look at this research, we want to translate into practice as well. So I know Bill recommended a long time ago on Twitter, I think, a podcast called The Skeptic's Guide to Emergency Medicine, which I really actually appreciate, because they do a systematic walk through articles. And one of the things they talk about a lot is translation, you know, translating it from the improved scores and things like that to improve patient care, to improve patient outcomes. So,
Yeah, they like to do knowledge. They want to take the time for knowledge transfer to go from 10 years to 1 year is
Yeah.
their big saying that they talk about, because it takes so long often for things to actually make it out of the lab or wherever it is and get translated into actual practice. There's a whole, again, there's a whole discipline on translational education
translation.
stuff. So.
It's gaining ground too in terms of research. So, all right. So we have our next pick, Alex. Alex Tremblay selected an article for us on health humanities and EMS. Call to action.
Yeah, I picked an editorial to be a rabble rouser, I guess, and I asked that they add to the chat a really great article from 2012 about the benefit of medical editorials in peer-reviewed journals compared to like a general editorial that you might find in like a newspaper. So please take a look at that. There's actually some really great research about the foundation of using previous guest editorials in developing new research, so long as they also meet the core requirements of being published in peer review journal. But essentially what this is, this really stuck out to me as a shortcoming of the way that we train paramedics academically. And I specifically am pointing at paramedics because the program is longer, right? And this editorial, the Health Humanities Emergency Medical Service and Emergency Medical Services, a call to action by Dr. Morse et al. From Johns Hopkins, is really imploring program directors, like some of you on the call and some of the folks on this panel, to consider implementing a requirement to take some humanities courses as part of your paramedic program education. There's research out there that I'll happily share that exposure to the humanities likely will reduce physician burnout. Hasn't been an EMS study, maybe because it's not currently required in most EMS programs. But getting students, especially young students, I was 18 when I started paramedic school. That was Dave let me do that, and I think hopefully he was right that it paid off. But
it was right. It's a
yeah.
great decision.
All right. So getting students into classes like anthropology, the arts, any sort of literature review, the core 3 programs defined by these research groups of what medical humanities are or health humanities are bioethics, clinical ethics, and literature in medicine. So finding ways to get students into these programs where they might see things that they haven't seen before from a social perspective might be incredibly important. I'm reminded when I left my EMS program and went on and did my bachelor's, which is in math, we had a requirement to take 12 credit hours of humanities, and one of the humanities courses was medical ethics and sociology. And it's like, man, I wish I would have taken this before. I wish I would have had the opportunity to hear these ethic conversations and what it means to really be part of the healthcare system. And when Megan was talking about community health workers, and we're talking about the Child Opportunity Index, what we're really talking about is the structure by which we do our work, and to widen the lens on the structure by which we do our work away from I'm going to provide excellent care, do my handoff, and move on, is to understand the humanity of it all, and to understand those things like taking a lit class is going to be excellent, especially a medical literature class, as people write either creative nonfiction or fiction accounts of their time working in medicine. Is it going to close that opportunity gap or that knowledge transfer as much? Maybe not, but what it is going to do is going to make more well-rounded clinicians and likely find an opportunity to reduce burnout in the providers if the research on physician students is similar for the research on paramedic students. And so that's why this stuck out to me.
Bill, you posted something in the chat here about diagnostic errors in the emergency department. Did you want to comment on that?
Hold on.
Looking for that mute button.
Yeah, I put it up there just in our thing to just generate some discussion, but that's I just saw that posted in CNN. as they've captured onto this report that came out talking about diagnostic errors in the emergency department. And again, anytime you talk about something that happens in the emergency department, there's a chance that it may translate into the out of hospital. Not always, that can be a mistake, just because they do it in the emergency department, we should do it in the field is not always true. But it talks about top things that are missed. And it would be very interesting. And this will only happen when we can get the linkage between the ECPR completed by EMS with hospital data to really know how many patients are we missing even the complaints on that really have critical outcomes. I would say for sure we do miss it. I know in my career, I have certainly missed stuff and that I should have picked up on, but who knows where I was at that time there. That's the only reason I threw that up there is for food for thought for us to discuss in the future.
Yeah, and we'll put these other links that are coming up in the chat also into the YouTube page at the bottom in the notes, so you can check it out. I'm curious because diagnostic errors, I wonder how much when we've been talking about social issues and social determinants and how much of this is going to be is due to a lack of understanding of the social issues. So we've had situations where paramedic students have been in an emergency department on their rotation and discovered a social issue, like someone unable to pay their heating bill, and they came in hypothermic and they were elderly and they didn't have they didn't have the resources to pay for their heating. And so just instead of just treating them and releasing them, a student has discovered that they're going to go home and not be able to pay their heating bill, and they're going to end up back in the emergency department. So I'm real curious about that. I think it's really fascinating that we're all choosing very similar topics. So, and now we're going to move on to another qualitative analysis. This was Kim's pick. Kim.
Hi there. Yeah, Alex, I just wanted to say one thing about Alex's pick first. And I think, when you look at the argument for, why should you have a degree in EMS? I mean, I think that this sort of helps to kind of support, like, what are the other things, like in terms of your depth of thinking that you need to know, that you need to think about. And actually some of it came out in this article, which I picked. It's a qualitative analysis, which I shouldn't have picked because it's always so much longer, of the mental health training and educational needs of firefighters, paramedics, and public safety communicators in Canada. The reason I picked this is because, ever since the practice analysis came out, the ALS practice analysis came out, and it showed that behavioral health emergencies are the second most frequent call types in children and the fourth most frequent primary or secondary impression in adults. It got me thinking about, how much are we doing? How much are we teaching people? And then also sort of stemming from some of Ginny Rankowitz's work, how can we do better in terms of this topic? So these are Canadian researchers, and they gathered together 19 paramedics, firefighters, and telecommunicators from two provinces, Ontario and Alberta in Canada. And they did focus groups and semi-structured interviews to try and answer the question about what kind of program content, what are the preferred modes of delivery, what should be the timing of training, and to whom should it be targeted for mental health. And so their introduction and their literature review is really worth reading because it talks a lot about strategies that are already being used and the relative success of those strategies. And they cite the increased incidence of suicidality, burnout, and compassion fatigue related to the frequent exposure of potentially traumatic events, morally injurious events, and other occupational stressors. And I thought maybe it would be good to define what is moral injury, because I honestly didn't know that until a few years ago. One of our training officers, Stephanie Ashford, was really great about integrating mental health topics within other topics. So when we did our annual a mass casualty incident, that sort of thing. Oh, I forgot to mention the other reason I wanted to integrate this is because I don't think we talk a lot about continuing medical education, and there's not a lot of research on it. And I think that it's really, really important. So moral injury is the suffering that people experience when we're in high stakes situations, things go wrong, and harm results that challenges our deepest moral codes and ability to trust in others or ourselves. And that harm may be something that we did, something we witnessed, or something that was done to us, and it results in moral emotions such as shame, guilt, self-condemnation, outrage, and sorrow. And so I think when you think about that, that sort of goes along with some of what Jenny Rinkowitz found, was that sometimes it's not just the big stuff that happens, it's the smaller stuff, those smaller stressors that sort of happen on a day-to-day basis. So they ended up getting 19 providers, 10 firefighters, 7 paramedics, and 2 public safety communicators. And they came up with 3 major themes. So the first theme was the mode of delivery, and there were 3 sub-themes under there. The first was checkbox training. People felt like, employers were sort of doing that asynchronous training just so they could check that box and say, oh yeah, we did training on resilience and we did training on mental health, but that often that it wasn't really specific to the public safety population. The second sub-theme was too early or too little or too late, and that they felt like it should be delivered early in their careers. Although at that point in your career, sometimes people really aren't ready to hear the fact that you might have a lot of stressors and how it's going to really impact your life. And that they felt like their core values changed during their careers because of the exposures that they received. The third sub-theme under that main theme was that once is not enough. That again, that employers felt like just doing a one-off education, check that box, and that was going to be good. That you need to, that the leaders could just say, oh yeah, we gave you that moral injury course, so everything is good, that you should be fine now, and that there should be a focus on making the workplace culturally safe, so that there should be more of a systematic approach to mental health that doesn't just rest on the individual, that they felt like a lot of the courses were focused on you as an individual and what you can do. And one of the quotes was, it's just like if you go fishing, you're not going to expect a fish to jump in the boat. You can't just go fishing and be like, where are all the effing fish? They're not jumping in the boat for us. That management really has to look at what can we do as a system to make this better. Then the second theme was an organizational matter. So misunderstanding of roles, that there was a lack of leadership training to be able to support employees' mental health and resilience, that there was a lot of negative interaction when an employee approached leaders regarding mental health, saying, oh, you're just not cut out for this, or they can't handle it if they come to me with these issues. Another sub-theme was organizational, not personal resilience. That again, training was focusing only on the individual. And, they felt that the current courses were just sort of like putting a Band-Aid on a broken leg. And that organizations needed to foster a culture of respect, dignity, and psychological safety. And the third sub-theme there was that psychologically unsafe workspaces. They reported their workspaces were toxic because of poor leadership culture or values. And that there was a stigma on health seeking ingrained in organizational culture. I've seen that before in employment that I've had. And that they felt that supportive leaders could really have a positive effect. And then the final thing was the holistic mental health training. And their initial point there was that there was a lack of training in the soft skills during entry-level education. So back to simulation, like Katie was talking about, that, they felt like there was as little as 3 hours of initial training on these topics, and that you had to learn how to navigate mental health issues by trial and error, or by watching other people, and maybe that wasn't the right way to do it. Mental health matters was another sub-theme, that the mental health of employees matters as much as the patients, and that the stressors can be just everyday benign stressors all the way to horrific stressors. And they felt like there was a big disconnect between the suggested strategies to support their mental health and the lived reality of their work. And then finally, that the last theme was, I need more than just breathing exercises. So that they felt like they needed more in-depth mental health education, and it should be given by somebody that understands, that somebody has worked in the field before. They felt a desire for intensive simulation training for both mental health scenarios, and then also simulation or role playing on how to support struggling coworkers. And so I thought it was great. I thought it really could provide a framework if you were leading a training division at a department. It's just like anything else. It sort of underscores the fact that training isn't a one and done. It should be part of a system approach. And you can't just fix everything by doing one training intervention, that it really needs to start at the top down. Anyway, there was a lot to unpack there. So I'm trying to make it brief, but it's tough for that topic.
Thanks, Kim. Bill.
So Kim, excellent point. And it to me, it continues to reflect back. Is our current curriculum for all levels of EMS providers as thorough as it could be? And is the amount of time necessary for a topic provided, and then scaffolding comes to my mind also, can we improve how we develop within the EMT or first responder? And then how do we build upon that base knowledge as they continue to go on? It's, and Katie touched on this. It's like, how can you really have a discussion on ethics when no one's really had the true training on ethics? And I know NAEMSP came out with a 1 or 2 day program on that. Well, I had a semester on an ethics and in education, and that didn't cover everything that needs to be done, because I do think that all EMS providers should have to have ethics education. The other thing that's just not well covered at all, and it really was, I was so surprised that it wasn't until I was halfway through my career that I read Helen Kubler-Ross's book on death and dying. And it went through my mind is, why didn't I get this in my EMT class? And why wasn't I reading something like this then and having these discussions then? And so I really think that while I know these soft skills that someone may refer to them at doesn't seem as exciting as laying underneath the table in the dark with a flashlight in your mouth, intubating someone. I understand that, but that's really so rare of the kinds of events that EMS providers are on. And a sidebar is, when I worked in Kansas, we had an Airway registry database, and we looked over well over 1,000 intubations, and only once was there ever a patient intubated. Well, it was actually a supraglottic airway sitting upright in a car. But yet think of all of the times we spend creating these scenarios of what I think are, there's probably a place for those unusual things, but, we need to make sure they know how to do the day-to-day stuff.
Right. One big example that I think is a real thing that lacks is every protocol for chemical restraint or restraint says, begin with verbal de-escalation. But how much do we practice that? How much do we teach that? How much is written about that? So that's one of my missions, is to try and, bring that to the forefront so people know what is that. And yeah, anyway.
Well, and you and I have talked about this offline about within EMS textbooks, how poorly mental health issues are covered. Mm-hmm. And yet they make up this huge component of the scope of practice type thing, or what people have found that they're lacking, but yet the resources aren't there for them to have it, compared to other countries that have written entire books, like out of Australia or in England, on the topic of emergency mental health.
Yeah,
for pre-hospital providers.
I
Yeah,
agree.
I'm just gonna plug that NAEMSP statements that was all released today. It's all open access, or not today, this year, all open access. And part of what they're saying around education is you got to think about how much time you're spending on it. Because the amount of time that you spend in the classroom, in the skills lab, the amount of times you make someone do something. So I know in EMS education, we have a big thing about record how many times they start IVs, record how many times they do intubations. If you're saying that you have to do 24 intubations to graduate paramedic school, we're saying that's important, but then they don't have to practice 24 times of BVM ventilation or 24 times of positioning the airway appropriately, or I don't know, talking to somebody who's in crisis. There's 0 check boxes for that. So
There are
by
0
not having a
check
checkbox, if you don't measure it, it doesn't count. Dr. Davis told me that a million times. So we just really have to be careful about that. The amount of time we spend on something is telling our students what's important. And if we don't spend time on something and we're not talking about it, we are telling them implicitly that it's not important.
I agree.
I think we can take that one step further and say you have to tell the students too, right? What do we see on all of our RAM surveys? I want to spend more time intubating. I want to spend more time, excuse me, in the lab. But that's so few of the calls they go on, but that's what they want. I need to touch the laryngoscope more. Except 99% of your calls are about talking to people, 1% of them about intubating people. So I think our educators have to know, and our students have to be told how incredibly important being able to communicate, de-escalate our patients is, so that they recognize that's why this is such an important area.
I think a lot about because I work in the continuing education side. I think a lot about the people I talk to that go to nursing school, like our paramedics that are in nursing school. And the number one complaint they have is how many classes they have to take about talking to people and how few hard skills they have, which is funny, right? And I think about now I'm looking at I'm comparing the paramedic AS and the RN AS at the nearest community college to my house. They have to take the RN track has to take 12 to 18 credits on social inequities, interpersonal communication, medical anthropology. Social inequities alone, after we've talked about it today, would fundamentally change foundational practice for a number of providers, especially providers in interesting areas of social determinants of health, right? Or interesting social demographic areas, like where I came from professionally. And so it's funny to hear we never practice IVs, and all we ever do is practice talking to people and doing an assessment through like verbal means, but somehow that seems to be working. Like there seems to be some special sauce there. So Kim, I thought this was excellent.
Great. Any other comments about this one? What I'd like to do is move to we just went through all of our panelists. We want to move to what's on the horizon. And actually, I'd like to skim through the panelists and see if you guys would just give a quick recommendation for reading over the break. If we have educators over there that have a break, maybe over winter break, do you have a recommendation for a good book or good reading and a podcast listening? Because everybody listens to a podcast here and there. So how about a quick recommendation? Let's start with Mike.
Thanks, Megan. My reading is going to be an investigation of preceptorship of emergency medical services and paramedic interns. This was actually published by a role model of mine and our paramedic program director here at UCLA. And we've already implemented some changes. One of the big things that they've already implemented is a fire department culture 101 class for students who don't come from the fire department. We recognize there's a culture there. You have to be able to recognize what you're supposed to do when you get there. The chairs you're supposed to sit in, the chairs you're not supposed to sit in. Really looking forward to reading it. It's his EDD publication. So looking for that. In terms of podcasts, I listen to a bourbon podcast. I'm looking forward to catching up on some episodes there. We all have to unplug and build our resiliency. So that's what I'll be listening to.
Which one was that? Say that one again.
Oh gosh, the podcast.
Yeah.
Oh, you're gonna make me look it up. I was it's like the Bourbon Trust or something.
Okay.
It's called let's see, The Bourbon Pursuit. That's
The
what
Bourbon Pursuit. All right.
More importantly, I'll be reading some important information.
Katie, how about you? Do you have a reading recommendations podcast?
Yeah, so I have to catch up on my medic mindset. I actually just need to go back to a couple of years of the different ones. And then Ginger and Maia had done this like book club of like what they are reading, and they had like 7 books. And so I think it was released in April, and I maybe made that list. And I'm hoping that on my multiple flights this Christmas season, I have some time to read those books. So that's where I'm at.
Great. Thank you. Alex?
Okay, so podcast wise, I, much like Michael, listen to a lot more probably entertainment based ones. So I'm going to recommend Deeply Human, which is by a local musician here in the Twin Cities who interviews people about things like sleep, and it's very good. It's anywhere you can find a podcast. And for reading, I have 2 for all of you. I recommend that anybody that's new in their leadership journey or looking to try something different picks up Michael Lipsky's book on the theory of street level bureaucracy. It's a 30-year-old theory that was originally coined at the University of Wisconsin, which is a terrific learning institution. And if that piques your interest, which I do think it probably will, the follow-up would be to go and look at Lars Tummer's research, which is about policy implementation and the importance of discretion in workers that don't have direct leadership oversight, which is very specifically what we do in public safety. So give it a try and shoot me a message if you need help finding it.
Great. Thank you. Kim?
As far as a book, I really like the book Making It Stick. It's all about the science of learning. It's Brown, Rodinger, and McDaniel. And then podcasts, which is what I do a lot of the time, when I'm walking or driving. I really like Faculty Focus. It's not a full hour. Usually they have 2 or 3 speakers talking about different things in higher education. And then there's a great podcast that's been around for a while called Teaching in Higher Education.
Yeah. That's a great
and Bonnie Stahovic, and often she has just incredible speakers on, and just really makes you think differently about things, like things like grading, and a whole broad swath of topics. So yeah, those are my picks.
Thanks. How about Bill? Dr. Toon, do you have any reading and podcast recommendations? Here's the reading. Mental Health and Mental Illness in Paramedic Practice by Robertson Haynes.
Yeah, that will be my fall reading, is that one. I've already picked up about a half a dozen other books. I'm not sure how many I'll get through now or in the future. And I have many more. I have tons of podcasts that I listen to, and I get always behind in them. But you already heard my favorite. It's the Skeptic's Guide to Emergency Medicine is truly still one of my favorite, because he does such a nice job and structure reviews of papers and everything. And also my reason for reading this is Dave Page came to mind as, there might be some insight I could have with this and dealing with Dave and stuff.
Speaking of Dave Page, do you have any reading and podcast?
Yeah, I might have to read that just to learn how to deal with my own self. That would be a good one. I love it. I love all these recommendations. I was going to put up on the screen, but I think you have to enable me to screen share a shameless plug for on December 20th.
Yep. Actually, that's our next slide.
Oh,
there
good.
We go.
Good. On December 20th, I think if you can tune in, and if not, check us out on the replay in YouTube. There's a wonderful opportunity here. The Diversity, Equity, and Inclusion Committee from NAEMSP did a scoping review of EMS workforce disparities. And this is, I think, a really good opportunity for Dr. Rudman, Dr. Farcas, the entire team, which includes Remley Crow, to really talk a little bit about the hundreds and hundreds of articles that were part of this scoping review. And save the date, because we set another date in January 19, 2023 at 2 p.m. Eastern, 19th of January, 2 p.m. Eastern, for a clinical disparity scoping review that just published by a similar group, Dr. Farcas, Dr. Joyner, and there's Dr. Hamid. It's a really strong paper on all the clinical disparities. Aside from that, so tune in on December 20th at 2 p.m. Eastern and January 19th, 2 p.m. Eastern. I liked Owen Trainer's suggestion of an oldie but goodie called How We Learn by Benedict Carey. I know Kim will be tickled by that suggestion. I personally am going to be listening to a guilty pleasure called EMS Sirens with Kevin Hazard. It's an audiobook, and that's the story of Freedom House, and just published, and they'll be attending NAEMSP, and he and John Moon will be doing appearances in the South Carolina EMS conference. So it'll be around. I'd like to listen to that. And How to Be an Anti-Racist is another one that I'm going to listen to. Ibram Kendi, and that was a Heather Davis suggestion. But I love the others because I listened to Ginger, and that podcast about what to be reading with Maia Dorsett was just phenomenal. So great.
I'd also recommend the EMS Educator podcast for those listening to education. EMS Lighthouse is another good one. And PEC. PEC reviews, PEC podcast reviews some research if you really want some systematic research review.
Love those.
Consuming the research. Great. Thank you. All right. Thank you, everyone, for joining us. And thank you for being here for all of 2022. We look forward to seeing you in 2023. And that previous slide said there's an abstract deadline, too. Remember, there's an abstract deadline, June 30th, 2023. Start thinking about what kind of research you can pull together from your education program from your area. And join us in the meantime in maybe next Tuesday, if you could. Will be recorded for the Workforce Diversity podcast, and otherwise we'll see you in January. Thank you, everyone, and have a safe and healthy. We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at www.pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website at www.prehospitalcare.org. A special thank you to our sponsor, Limmer Education, providing education tools for success at every stage of your EMS journey.